Good day. I'm Dr. Joyce Humangit. I'm a assistant professor at the Department of Medicine of FU and RMF. I'm here to lecture to you about hypertensive heart disease. Question first to everyone. All the following are examples of hypertensive heart disease. Coronary heart disease, LVH, LVF, or LV failure, arrhythmias, conduction system abnormality, and aortic regurgitation. What's the right answer? All of them, true or false? Well, it is all of them because hypertensive heart disease is defined as constellation of abnormalities including coronary artery disease, LVH, systolic and diastolic function, and their clinical manifestation including arrhythmias, conduction abnormalities, and symptomatic heart failure that are caused by the direct or indirect effects of elevated blood pressure. So what are the perspectives for hypertension? Actually, hypertension is defined as a blood pressure greater than some number. It's usually 140/90. However, experts are beginning to realize that what we call hypertension is really not a number, but a syndrome. Hypertension is a syndrome of 1. Elevated blood pressure, expanding girth, obesity, dyslipidemia, and glucose abnormality. What's the burden of the hypertensive heart disease? So for the global burden, majority of our patients, around 22 to 27%, had a BP of more than 140/90 globally. If you try to take a look at France, it's about 6%, and 24%. In England, it's about 6%. For 160/95 blood pressure, the highest pointer for this one would be Germany, followed by Finland at 20.5%, Spain at 20%, and Australia at 19%. So what's hypertension control in the Asia Pacific region? So if you try to take a look at the Philippines over this area, the prevalence rate of the Philippines for hypertension is 21%. Almost 75% are aware that they're hypertensive. Only 65% are being treated, and only 13% had control or adequate control. Although it is almost similar than the United States, in Asia Pacific, ours is one of the highest. What are the types of hypertension? We have essential and non-essential hypertension, or primary or secondary hypertension. Essential hypertension comprised of 95% of all hypertensive patients. That means there is no underlying cause of the hypertension. And secondary hypertension means there is a primary or underlying cause. What are the causes of secondary hypertension? Well, one example is renal, parenchymal, vascular, or others, or endocrine, or other causes. And worse is unknown. Let's treat hypertension beyond the targets. What do the guidelines say? Now, we have actually 4 guidelines that I'm going to discuss right now. And the latest guideline is the International Society of Hypertension Guideline of 2020, which was just published and released last May 2020. And also the ESCASH 2 years ago. So if you try to take a look at it globally, in 2017, the American Heart Association had their own guidelines, the ESC in 2018, even Japan in 2019. That's the reason why the ISH, or the International Society of Hypertension, wanted to put up the guidelines internationally this year. But if you notice, since I mentioned a while ago the prevalence rate of hypertension amongst these countries, the prevalence rate of hypertension in the United States or in several parts of Europe and also in Japan are low. The highest incidence of hypertension belong to the poor or low-income countries, like in Africa, wherein there's a lot of hypertensive patients. Because obviously, these people or these countries cannot afford to treat their countrymen properly. So, how do we measure our blood pressure? There are several types. We can do ambulatory BP measurement, home BP measurement, clinic BP measurement, manual, or automated. Now, the blood pressure, when they say that when the blood pressure becomes higher, the outcomes becomes worse. So the higher the sicker. So in terms of cardiovascular, absolute cardiovascular risk, hmm, increasing blood pressure, which is the x-axis, is compared across against mortality risk in the y-axis. That as the blood pressure gets higher, the risk becomes higher. So a patient with a BP of 115 over 75 had a usual or had a cardiovascular risk the same as a normal individual, but a patient whose BP is 170 over 105 had an eightfold risk of having cardiovascular mortality because of a very elevated blood pressure. The risk of CV death actually doubled with each increase of 20 millimeter mercury in systolic blood pressure or around 10 millimeter mercury in the systolic blood pressure. There are two types of measurement. You have the manual and automated. In the manual measurement, BP is measured using a manual mercury sphygmomanometer or an aneroid device. This is actually done by the healthcare. And then for the automated, the BP measurement using an automated oscillometric device is used and usually done by the patient himself. What is the recommended device? The electronic or automated device is recommended to record blood pressure because it provides more reproducible results than the older auscultatory method and is not influenced by variations in technique or by the bias of observers. This is the sprint trial, which is the basis of the American guidelines of 2017. Um, the American guidelines, the HA guidelines, base their blood pressure reading in the sprint trial, wherein in this sprint trial, they used non-invasive oscillometric blood pressure kits to measure the blood pressure of the patient. In the sprint, measurements of blood pressures were exceptionally well standardized and taken in the office setting by a fully automated device after patients had been seated quietly without observer being present. The variance with the measurement techniques that we use in the hot accord and the SPS3, all for optimal BP targets, they used their own blood pressure, but this one, we used the non-invasive oscillometric method. Automated BP monitor was the preferred technique in measuring the blood pressure in this study since it eliminates the so-called doctor variables or the white coat hypertension. Now, the first and foremost measurement of blood pressure that is recommended, highly recommended, and ideally done is automated blood pressure measurement. However, if this can be done because of the price or unavailability, then home blood pressure monitoring should follow in first, second, followed by office automated blood pressure monitor, and lastly, office manual BP monitoring. Now, they shun away from doing the office manual BP monitoring because of white coat hypertension. There's higher incidence of white coat hypertension if you try to measure the blood pressure of your patient in your clinic compared to those patients whose blood pressure were monitored at home with a relaxing condition. So for the ambulatory BP monitor, this is performed using a portable BP measuring device for 24 hours. This actually provides more reliable BP assessment and has been consistently shown to have a stronger correlation with CVD markers than clinic blood pressure. Whereas the home blood pressure monitor is performed using a home-based automated or semi-automated device, typically via self-assessment over 3 to 7 days. This provides a mean BP blood pressure over a long period of time than clinic or ambulatory readings, but it is not continuous. It has been shown to predict CV mortality and morbidity better than clinic blood pressure readings. For the office automated or manual BP monitor, this is performed with auscultatory or oscillometric automatic or semi-automatic sphygmomanometer. Unattended automated blood pressure monitor is recommended. The clinic BP is usually higher than both ambulatory and home-based BP assessments. This difference increases as the BP increases, and its accuracy is debatable. So how do you get your blood pressure checked? The first step in controlling your blood pressure is knowing your numbers, and that requires an accurate BP reading. So here's how to do it right, whether you're in the clinic or at home. So 30 minutes before, you should not be smoking, there's no exercise, and no intake of caffeine. 5 minutes before the measurement of the blood pressure, in the 5 minutes before your BP should be taken, you have to sit still. During the blood pressure measurement, make sure that the cuff is in the right size and in the right place. Keep your cuffed arm on a flat surface, like on a table at the heart level. Sit upright, back straight, feet flat on the floor, and don't talk. After blood pressure measurement, 1 minute after, wait 1 minute and retake your BP. And then get the average reading and consider 3 readings. And keep a log and bring it to the clinic every checkup. And bring your device yearly to make sure it is accurate. So this is how you get to measure your blood pressure. Now, in the real world practice, clinicians in the local setting still prefers the manual BP monitoring at the office, which should not be, as we have said. The new high blood pressure guidelines say, according to the American Heart Association, that the new hypertension or hypertensive is 130 systolic and diastolic of 80 or more. In the old high blood pressure guidelines, the cutoff is actually 140/90. Why is it now lower in the American Heart Association? You have to remember that in the American Heart Association guidelines, they use the basis, they use as a basis for their cutoff of the hypertension is your sprint trial, wherein the studies used home blood pressure measurements, automated blood pressure measurements, and made the cutoff lower. Okay, the American Heart Association actually removed the pre-hypertension level. Okay, so this is the normal blood pressure, 120/80. The recommendation for these patients should be healthy lifestyle choices and yearly checkups. Those patients belonging to 120 to 129 systolic and less than 80 diastolic, we say that they have elevated blood pressure and they are recommended to do lifestyle changes and reassess every 3 to 6 months. For those patients with 130/80 to 139/89, they say that according to the American Heart Association, they have already stage 1 hypertension. So the recommendation for this patient is 10-year heart disease and stroke risk assessment. If less than 10% risk, lifestyle changes reassessed in 3 to 6 months is recommended. If higher CV risk, then lifestyle changes and medications with monthly follow-ups until BP is controlled should be done. If your blood pressure is more than 140/90 or equal to it, this is already stage 2 hypertension. And the recommendation is lifestyle changes and 2 different classes of medicine with monthly follow-ups until the blood pressure is controlled. The question would be now is it time to adapt to change? Do we really need to put down the cutoff to less than 130/80 as hypertension? Now, before we answer that is, let me just show you what the European European Society of Cardiology and European Society of Hypertension presented with their 2018 guidelines for hypertension. So here, they still have the high normal. The hypertension stage 1 in American Heart Association is actually high normal in patients in the ESC guidelines cutoff. That's 130 over 85 to 89. For them, grade 1 hypertension begins at 140 over 90 to 159 over 99. Grade 2 is 160 to 179 and or 100 to 109 diastolic. And grade 3 is more than 180 systolic and more than 110 diastolic. And isolated hypertension should be less than or equal to 140 systolic and less than 90 diastolic. So they have conflicting views. So how come the European Society of Cardiology has a cutoff of much, or they are much more tolerant in terms of saying that the patient is hypertensive, simply because they relied on the measurements of the clinic blood pressure compared to the measurements of home blood pressures. So for them, the new high blood pressure or new hypertension is 140 plus or 90 plus millimeter mercury. The old high blood pressure is the same. Okay, so that's for the European Society of Cardiology. Now the question would be, which cut should I follow? I'm confused. Sabi nga ni Boris the Animal, let's agree to disagree. So let's take a look at the American Heart Association and the European Society of Cardiology comparison levels as to defining hypertension in terms of blood pressure. So in terms of office or clinic BP, for American Heart Association, that is less than more than or equal to 130 over 80. For the European, it's more than 140 over 90. Daytime mean blood pressure, same, more than 130 over 80. For the European, daytime mean blood pressure should be more than 135 over 85, same as the 2014 guidelines. For the nighttime mean blood pressure should be more than 110 or more and 65. And for the European is more than 120 over 70. 24-hour mean should be more than 125 over 75, whereas European has a 130 over 80. Home blood pressure mean should be more than 130 over 80, or for the Europeans, it's more than 135 over 85. In terms of combination therapy, in terms of treatment, initial combination therapy or initial single pill combination therapy is recommended in patients whose blood pressure is more than 20 over 10 millimeter mercury from the above BP or from the said target BP goal. That is according to the American Heart Association. But in the European Society of Cardiology, initial single pill combination is only recommended in patients more than 140 over 90 blood pressures. Hypertensives requiring intervention, the cutoff should be for the Americans more than 130/80, but for the Europeans more than 140/90. In terms of similarities, both the ACC and the ESC advise in terms of home blood pressure to take the BP at home twice in the morning and twice in the evening in the week before the clinic visit. Bring the blood pressure machine in annually for validation. For treatment, restrict beta blockers to patients with comorbidities or other indications. Initial single pill combination is recommended as an initial therapy. And then for follow-up, detect poor adherence and focus on improvement. And BP telemonitoring and digital health solutions should be recommended. So let's now compare the European guidelines to the International Society of Hypertension guidelines of 2020. In terms of treatment targets, the ESC has cut off of less than 140/90 for ages 18 to 65 years, down to 130/80 or lower if tolerated. For more than 65 years of age, it's less than 140/90 millimeter mercury, down to 130 over 80, if possible and if tolerated. For the International Society of Hypertension, ISH, the optimal means this is the ideal, and then all of your treatments are available for the patient. The cutoff should be less than 130/80, but individualized in the elderly based on frailty. For essential goal for hypertension, meaning this is the most important thing if you don't have the ideal setup. This is at least the basic goal that you should achieve to your patients. Reduce the blood pressure by at least 20/10 and ideally to less than 140/90 and individualize in the elderly based on their frailty. So the question or the answer to the question if what guidelines should be followed, then it is up to actually the attending physician. If you want to have the cutoff of 130/80 as the Americans do, then go ahead, you can do that. Or you can have the European guidelines. But as you could see, the European guidelines actually matches the International Society of Hypertension guidelines as per recommendation of their treatment. As Charles Darwin has said, it is not the strongest of the species that survive, nor the most intelligent, but the one that's the most responsive to change that survives. Now let's go now to the diagnostics. What are the basic tests? What are the optional tests? These are the basic and optional tests for primary hypertension. Basic testing should be fasting blood sugar, complete blood count, lipid profile, serum creatinine BGFR, serum sodium, potassium, and calcium, thyroid stimulating hormone, urinalysis, and ECG. This may be included in a comprehensive metabolic panel. EGFR indicates estimated glomerular filtration rate. Now, for optional testing, you may do echocardiogram, uric acid, and urinary albumin to creatinine ratio. Okay, so let's look at the CV risk factors. Those who are at risk, those patients who are male, black, okay, with genetic predisposition, with environmental factors like inactivity, stress, obesity, smoking, salt intake, and alcohol intake, and age. These are the people who are at risk of having hypertension. Okay, so how do we calculate the risk? But first, before we calculate the risk, we have to identify what are the risk factors. The changeable risk factors of hypertension would be one, overweight or obesity. We could change that. High sodium salt intake, alcohol use, lack of physical exercise, smoking, and stress. The unchangeable hypertension risk factors would be one, aging, two, race, three, family history, four, gender, and five, prehypertensive or gestational hypertension. Now, in order for us to calculate the severe risk of our patients, with the American Heart Association's guidelines, they came up with the AHA severe risk calculator. All you have to do is put in the age of the patient, the total cholesterol level, the HDL level, the systolic blood pressure level, whether the patient is on medication or not, whether the patient is diabetic or a smoker. Then the computation for your 10-year CVD risk would be automatic. So this is an app that you can use in your phone and compute for the CV risk of the patient. Another that we use is the ESC, ESH CV risk scoring. It is a table, just like what is in your screen right now. So let's say, for example, if your blood pressure is 140/90, so you belong to it on this one, and you have three risk factors. You have moderate to high risk. If you have organ damage or CKD stage 3 or diabetes, you will have high risk. Okay. And then this one, the third one would be the Philippine Lipid and Atherosclerosis Society CV risk checklist. This time, it's not a table, it's not a computation, but a checklist. What are the features of high risk? If your patient is more than 45 years of age, if the LDL-C is more than or equal to 130 milligrams per deciliter, and if you have two or more of the risk factors, such as being a male, postmenopausal woman, smoker, hypertension, BMI more than 25 kilogram per meter squared, family history of premature CHD, familial hypercholesterolemia, microalbuminemia, proteinuria, and left ventricular hypertrophy. So which to choose? Whatever makes you happy. Life is short. So either guidelines, either cutoffs, either treatment you can use. So what are the target goals? They say that lower is better, higher is soccer. What is normal again? BP of less than 120 over 80 was defined as normal. Setting the blood pressure setting the blood pressure goals actually is not an exact science. Such goals have generally relied on findings from clinical trials. And these are the target goals. So for the Europeans, for clinic-based normal blood pressure level, 120, 129, 80 to 84 millimeter mercury diastolic. For BP goals, with or without comorbidity, should be less than 140/90. For the American Heart Association, clinic-based blood pressure should be less than 120/80, and BP goals should be less than 130/80. GNC8, same with American Heart Cutoff of less than 120/80, but the BP goals is actually higher at less than 140/90. The ISH is actually for optimal treatment, it should be 130/80, or essential treatment, the goal should be less than 140/90. But BP goals with or without comorbidity should be less than 140/90. Now, this is an article to answer the question, what target goals should be followed. This is a meta-analysis which involved 123 studies, including the SPRINT trial. This involved 613,000 patients. Okay, so BP lowering was significantly reduced vascular risk across various baseline BP levels. That's more than 160 to less than 130. And comorbidities, except renal failure and diabetes, where reductions were smaller. A 10 millimeter reduction in systolic blood pressure actually reduced the risk of major cardiovascular disease events by 20%, coronary heart disease by 17%, stroke by 27%, heart failure by 28%, and all-cause mortality by 13%. These results provide strong support for lowering systolic blood pressure really to levels of less than 130 millimeter mercury. So how do we treat hypertension? Uguay say, there are no accidents. Yoda said, do or do not. There is no try. There is no guessing in the treatment of hypertension. The first thing that you have to do and advise your patient should be lifestyle management. What are the specific lifestyle recommendations? One, advice to lose weight. Follow a DASH pattern diet. That's a low sodium, low fat diet. Reduce the sodium intake to less than 1,500 milligrams per deciliter or per day. Increase potassium intake to 3,500 milligrams per day through dietary intake. Increase physical activity to a minimum of 30 minutes exercise 3 times per week. And limit alcohol intake to 2 drinks or less per day for men and 1 or less for women. So this is the American Heart Association classification and management of high blood pressures in adults. In patients with a normal blood pressure, all they advise is to have healthy lifestyle. For pre-hypertensive patients with elevated blood BP, elevated blood pressure, but not hypertension at all, and even those patients with stage 1 hypertension, still non-pharmacologic therapy, if the risk is higher than 10% for ASCVD risk of more than 10 years, then you have to add your BP lowering drug. But if the CV risk is less than 10%, you don't need to add, just continue on non-pharmacologic therapy or lifestyle management. For hypertension stage 1, definitely you have non-pharmacologic therapy and add BP lowering treatment. And they want to advise also to have either a single pill combination or a multi-pill combination, but they would prefer a single pill combination. Now, what are the drugs that work? You have your ARB and ACE. beta blockers, calcium channel blockers, and diuretic. For beta blockers, there has to be a class 1 indication, meaning there's a target or compelling indication for beta blockers when you want to use this. So you have A, B, C, D. You have ARBAs, beta blockers, calcium channel blockers, and diuretics. So what is the approach in the treatment? The monotherapy is the choice of drug. The choice of drug in monotherapy is influenced by many factors, including patient characteristics, comorbidities, and the drug profile. Monotherapy can effectively control blood pressure in only a limited number of hypertensive patients. Add-on therapy, whereas initiating with combination treatment is recommended in high-risk patients or those patients with very high blood pressure baseline. Combining two classes of drugs increases the BP reduction much more than increasing the dose of one agent, and many provide additional synergies. So again, it's better to have single pill combination rather than just monotherapy alone. This is the European guidelines approach in the treatment of hypertension. So for initial treatment, you have to have a single pill combination, either an ACE inhibitor, ARB plus a CCB, or a diuretic. We consider monotherapy in low-risk grade 1 hypertensive patients or in very old patients or frailer patients. On the second step, still the blood pressure is not controlled. We now do a triple combination. Still a single pill combination is advised. ACE or ARB plus a CCB or a diuretic. For step 3, we now do two-pill combination, that is triple combination and spironolactone or other drug to lower down the blood pressure. At this point, we're considering resistant hypertension, and adding spironolactone at 20 to 50 milligrams once a day dosing is actually helpful, and also adding other diuretics, alpha or beta blockers. We have to consider at this point to refer the patient to a referral center or specialist for further investigation. You have to be reminded that beta blockers should be considered at any treatment step when there is a specific indication for the use. Example of the indication: if the patient has heart failure, has angina, is post-MI, with atrial fibrillation, or younger women with or planning pregnancy. Okay, the core treatment algorithm is also appropriate for patients with hypertension-mediated organ damage or HMOD, like your cerebrovascular accidents, diabetes, and PA. So these are the indication of BP lowering treatment, lifestyle medication modification, and medication at different initial office steps. This is according to the European guidelines. So if you have high normal, you do lifestyle advice. Consider drug treatment in very high-risk patients. If you have grade 2 hypertension, still lifestyle advice, immediate drug therapy in high or very high-risk patients with CVD, renal disease, or hypertension-mediated organ damage. Drug treatment in low to moderate risk patients without CVD, renal disease, or HMOD after 3 to 6 months of lifestyle intervention if blood pressure not controlled. For grade 2 hypertension, 160 to 179 systolic, 100 to 109 diastolic, still lifestyle advice. Do immediate drug treatment in all patients. Aim for BP control within the next 3 months. For grade 3 hypertension, again, we have lifestyle advice, immediate drug treatment, and again, aim for BP control within the next 3 months. Okay, so what about those patients with hypertension and coronary artery disease? Again, for the first step, you have to have dual combination of ACE or ARB plus a beta blocker or CCB, or a CCB plus a diuretic, or a beta blocker plus a diuretic. We need to consider monotherapy in low grade 1 hypertension or in very old patients. For step 2, triple combination of the above should be considered. We should consider initiating therapy when systolic blood pressure is more than 130 millimeter mercury in these very high-risk patients with established CVD. And 2 pills, again, so step 3, doing the 3-pill combination plus a spironolactone, or we're actually treating already resistant hypertension by adding spironolactone at 25 to 50 milligrams once a day dosing, or other like diuretics, alpha blocker, or beta blocker. Again, if the patient reaches on this stage, then we have to call the patient's attention and refer the patient to the specialist for further investigation. Now, for the comparison of ISH versus European guidelines in terms of the target population, ESC focused on optimal care, ISH, optimal care when possible, essential care as a minimum requirement. BP classification is almost similar between the ESC and ESH. Hypertension is more than 140 over 90. For the diagnosis of hypertension for the ESC, office blood pressure is used for screening. Confirmatory is ABPM, home blood pressure, and repeated office BP measurements. For ISH, optimal should be same as ESC. Essential should be official BP, confirmed with ABPM or home blood pressure if possible. For cardiovascular risk assessment, high risk for ESC is CV disease, CKD3, diabetes, and hypertension-mediated organ damage. CV risk assessment in all others. And now for the ISH, it's similar to the ESC. CV risk assessment, though, is not specified. For drug treatment and BP thresholds, drug treatment and lifestyle for ESC. For grade 2 hypertension, drug treatment and lifestyle. Grade 1 in high-risk patients. Grade 1 in low-risk patients after 3 to 6 months of lifestyle intervention. Now, for the drug treatment in the ISH, it's the same as the ESC. And then essential, we have to focus on grade 2 and high-risk grade 1 if resources are limited for treatment. In terms of lifestyle intervention, Europeans would recommend smoking cessation, healthy diet or drinks, reduced fat, salt intake, alcohol moderation, weight loss, or weight control, and regular exercise. For ISH, is the same with ESC. Optimal, though, is in addition, stress reduction and avoid air pollution is advised. For the initial drug treatment for ESC, it is drug single pill combination for most patients, usually an ACE or ARB plus a CCB, or an ACE or ARB plus a diuretic. Beta blockers is used only when indicated, other drugs for specific indications. Now, optimal for ISH, ideally, we have A plus C, single pill combination for the most, or C plus D in patients who are Black. Other drugs, same as ESC, ESH. Essential treatment should be given, same as above, if possible, or any available drugs proven to lower the blood pressure. Now, for further drug treatment, triple therapy is ideal as a single pill again. 4 drugs for resistant hypertension, adding spironolactone in other drugs if needed. And then for the ISH, for optimal treatment, the same with the European. For essential, as above, if possible, or any available drugs that's proven to lower down the blood pressure of the patient should be used. So what are the treatment targets? For ESC, less than 140/90. For ISH, essential should be less than 140/90. For optimal should be less than 130/80. For monitoring the treatment, ESC and ESH aim for blood pressure control within 3 months, monitor the side effects, and check adherence if BP is not controlled. For optimal and essential treatment for ISH, aim for BP control within 3 months, monitor for side effects, monitor for adherence. For cardiovascular risk management, ESC and ESH recommended statins for all high-risk patients. We consider statins for moderate to and low-risk patients, antiplatelets for secondary prevention. And however, for the ISH, there is no specific recommendations. But you have to take note that the combination of ARBs, according to the speech trial, is a combination to reckon with. Why? In the accomplished trial, around 11,506 patients were studied, they tried to take a look at the combination of ACE inhibitor plus CCB versus ACE inhibitor plus a diuretic. They followed up the patient for at least 2.5 years, and it was shown there that benazepril with amlodipine was associated with reduced severe risk mortality or morbidity events, as well as small but significant decrease in the average blood pressure. So what are the recommendations for the American Heart Association for the takeaways of treatment? Again, anything above 140/90 needs to be treated. So basically, all of the guidelines that we have discussed, actually the treatment should be the blood pressure of more than 140/90. When you have that, those patients should be treated. Anything above 130/80 needs to be treated if the patient had a CV event or is at risk of CV event, that is based on age, presence of diabetes, CKD, or calculation of atherosclerotic risk. The goal of treatment should maintain the blood pressure to under less than 130/80. Specific lifestyle recommendations as mentioned: weight loss, DASH diet pattern, reduce sodium and potassium intake, and then increase physical activity to minimum of 30 minutes of exercise 3 times per week, and limited alcohol intake to 2 drinks or less per day for men and 1 or less for women. So for this patient, MPOI, stage 1 hypertension, blood pressure is 145/90, ASCVD risk factor is less than 90, is less than 10%. We can give monotherapy, yes, power of protection, but we can also do, if the patient has stage 2 hypertension with the ASCVD risk of more than 10%, we can do combination treatment, the power of 2 for you. Now, cardiovascular risk of hypertension. Hypertension is associated with a number of serious adverse effects. The likelihood of developing these complications varies with blood pressure. The increase in risk begins as the blood pressure rises at above 110/75, and at any blood pressure, it is importantly affected by the presence or absence of other risk factors. So what are the target organ damage for hypertension? So hypertension can cause all of these changes in the brain, in the vascular bed, in the heart, and in the kidneys, which could later on lead to stroke, hypertension, heart failure, renal failure, and eventually death. So CV mortality risk doubles with each 20/10 millimeter mercury increase in the blood pressure. So for these patients, the relative risk of 115/75 is 1:1. For more than 135 would be relative risk is twice double the risk, and 150/95 quadruple the risk, and of course 175/105 you have 8 times the risk of developing severe risk or poor cardiovascular outcomes if the blood pressure is uncontrolled. Now, lowering blood pressure is imperative in reducing CV risks. Why? Because myocardial infarction is decreased in around 20 to 25%. Stroke is decreased at around 30 to 35%, and heart failure is decreased to around more than 50% if we lower down the blood pressure of our patients. So again, what are the drugs that work? We have the ARBs, ACE inhibitors, beta blockers, calcium channel blockers, and diuretics. What are the drugs that can be used for LVH regression? Least effective would be direct vasodilators. Mildly effective would be diuretic and beta blocker. Mostly effective for LVH and regression, or for LVH regression, is ACE inhibitor or ARB and a CCB. Data indicate that the regression of ECG LVH is associated with less hospitalization for heart failure in hypertensive patients. Drugs for diastolic dysfunction and diastolic heart failure. They recommend ACE inhibitor, beta blocker, non-dihydropyridine CCB. One good example is candixaptan coming from the CHARM trial. Careful addition of diuretics and nitrates, and please avoid hydranazine. Drugs for LV systolic dysfunction. Beta blockers, which are those beta blockers should be cardioselective or with mixed alpha and beta blockers or beta receptor blockers. ACE inhibitor, ARB, diuretics, MRA like spironolactone or eplerenone, and please, for LV, with patients with LV systolic dysfunction, no CCBs. For drugs for hypertension with high coronary heart disease risk, ACE or ARB, CCB, beta blocker, and a diuretic. Drugs for hypertension with chronic coronary syndrome or chronic stable angina, beta blockers would do, CCB would do, nitrates would do, ACE inhibitor ARBs would do, and also diuretics. Drugs for hypertension with acute coronary syndrome, you can have beta blockers, ACE inhibitor ARB, nitrates, and CCB like your amlodipine with beta blocker. Drugs for hypertension post-MI, you can give beta blockers, ACE inhibitor ARB, MRA. This is recommended for use in post-MI diabetic patients or patients with an EF of less than 40%. What's the goal blood pressure in all cardiac patients? Is it less than 140/90? Is it less than 130/80? Less than 120/80? Less than 110/60? Again, the cutoff would be less than 130/80. What proportion of hypertensives should take statins? What do you think? All patients should take statins? Or almost all? Only a few with significant dyslipidemia? The answer is almost all. Why? Because hypertension is a significant risk factor for coronary heart disease. Dyslipidemia is common in hypertensives. Antihypertensives often is inadequate to reduce the risk of cardiovascular death. And reducing risk even when BP is normalized is needed. And again, giving statins to patients shows good evidences in the randomized controlled trials that have been done. The question, will you recommend aspirin for primary prevention in all hypertensives, those at high risk only, or almost all hypertensives? Ideally, it should be all hypertensives, but for essential, it can be also almost all hypertensives because of the said life-saving RCTs that were done with aspirin in the primary prevention treatment. So, to end, treating beyond targets, you have to know your patients. You have to look at the severity of your patients, know your numbers, what's your target BP, what's your cutoff, know your meds, its action and effects, and know when to adapt guidelines based on know when to adapt based on the guidelines or based on real world practice. Again, change happens, winners adapt and move on. Thank you very much.